Good morning.
Good morning.
Thank you so much to President Bachman and to Reverend Funderburg, Reverend Cleveland, to our distinguished guests and sponsors from United Healthcare, to my comrades and colleagues in the faith community, to brothers and sisters all. It is my happy privilege to welcome you as servant leader here to the historic Trinity African Methodist Episcopal Zion Church. For over 130 years, this congregation has served God and humanity here in the Gate City. We've been a vanguard for justice and on the front line for civil rights and human rights for all of God's children, most particularly the dispossessed and the disinherited, who, in the words of that great mystic preacher, Dr. Howard Thurman, have had their backs against the wall. As we peer through our windows into the world we traffic in today, we're painfully reminded that the struggle continues and that houses of faith must be ever so vigilant to respond to the calls and cries of those languishing under the weight of poverty, injustice, and inequity. Hence, our gathering this morning is of the greatest necessity, and we take this moment very seriously. We've partnered with United Healthcare to navigate a path that will not only speak to the issues we face, but to also find meaningful, impactful solutions that will span the ever-widening chasm between the haves and the have-nots, the rich and the poor, the least, the last, the lost, and the left behind. Particularly in communities such as East Greensboro, where this church and many other churches and faith communities are situated. We're mindful of the words of sacred scripture that enjoin and command us to be a voice to and a voice for the helpless and hopeless in our society. So let me once again welcome you to what I hope will be a meaningful conversation. Let me thank those who are joining us in person, as well as those who are joining us virtually this morning. My hope is that this pilot and pioneering work will have roots and wings as we attempt to serve this present age, spurring and prompting the kind of work that will transcend the vacuous grandstanding that we see and the vicious attacks that we see often when it comes to justice and equity for the overlooked and often ignored. I celebrate this partnership this morning that is being forged and formed between faith communities and collaborations and United Healthcare as we seek to raise the octave of justice and fairness with regard to health and healthcare. So let's get to work, and may this good work begin with us. Once again, I bid you welcome, and may you know that this loving congregation stands ready to attend to your needs while you sojourn on our campus. Again, welcome. Thank you for joining us, and may God's blessings be with you all. At this time, I want to introduce the president of United Healthcare for all of North Carolina. Welcome with me, if you will, both online and virtually or in person. Would you join me in welcoming Ms. Michelle Bachman? I'm sorry, Anita Bachman. Good Lord, Anita Bachman. Welcome, Anita Bachman, will you please?
Well, thank you, Dr. Mitchell. What a pleasure it is to be here with all of you today, and what a pleasure it is to really partner with you, with the church, and many others that are here today. Again, I'm Anita Bachman. I have the privilege of being a part of a team at United Healthcare whose mission is helping people live healthier lives and making the healthcare system work better for everyone. I think no time like today to really make progress. I was reflecting as I was driving here this morning about health and healthcare. And I was reflecting about how much the definition of health and healthcare has changed really over the last 5 to 10 years. And You'll probably remember with me maybe 5, maybe 8 years ago, as we talked about health, the first thing we thought about when we thought about health was, were we going to the doctor? Were we going to the doctor's offices on schedule? Were we getting our medications? Were we taking those medications as prescribed? And were we getting that physical activity? And those, I think, were the 3 main things that we thought about in improving our health and living a healthy life. But we fast forward to today, and I think really over the last 5 years, we've begun to think about health in a much more comprehensive and expansive way. And I think in the right way. And that is health in, and thinking about it this way, that 20% of a person's health, 20% is based on those 2 things I mentioned. Going to the doctor, getting those prescriptions filled, a little healthy exercising, healthy eating. But it's that 80% that truly does impact a person's health and impact a person's life. That 80% including, do they have a job? Do they have the training necessary and needed for a good job? Do they have housing? Affordable housing, not just housing. Do they have access to good, healthy foods? Do they have the ability to be able and the knowledge to be able to prepare those good, healthy foods? Do they know how to purchase those healthy foods? So those are some of the things that really represent that 80%, and that's why we're here today, to talk about how we work together, how we partner to really improve the health of our community, health of Greensboro, health of the state of North Carolina. I'm excited about many things that United Healthcare is doing. I'm excited, more importantly, about the things that we can do working together. Dr. Mitchell mentioned a little bit about our reference to East Greensboro. And I think about East Greensboro, and I think about other parts of our city and of our state that really does suffer from health inequities. And those exist, as we know, because of historical issues, but also present-day realities. Some of that really exacerbated by racism, by discrimination, all that impact access to health, access to housing, education, those things that I mentioned that are in that 80%. We also know, as a part of health inequities, that African Americans experience the highest rates of heart disease, cancer, stroke, asthma, diabetes. We all see the numbers, we all see the data, right? I was reading a report that we just distributed a few months ago, the America's Health Rankings, a staggering statistic. North Carolina ranks 35th in low birth weight, and much of that having to do with the racial disparities. And as we know, that's unacceptable. We can do better than that, and we are going to do better than that. But it's going to take all of us working together, right? It's going to take collaboration and partnership to make a difference and to make that progress. As a child, I grew up in a rural part of the state, Oxford, which is near Durham and Raleigh. I don't know how many of you know that little town, very rural. As a family, we didn't have access to health care. It was there. But given the way in which we lived, we struggled. We had a farm, and what we ate was what we grew on that farm. When we needed access to health care, we sometimes had to struggle to get that access to health care. And as I fast forward to today and think, you know what, we can all do better. We can all ensure that there's equality, there's equity, more importantly, with each and every person that lives in our city, each and every person that lives in our state. My dad once said, as I was a child, I think he called me a stubborn girl, but he always said, you know what, if you put your mind to something and you work really hard, you can make good things happen. But you can only make good things happen when you surround yourself with people who have the same interests and the same goals. And so I'm excited about all of you being here today. I'm excited about this really important discussion because it is going to take all of us working together to make a difference, and I know that we can. So again, thank you for your partnership here at the church. Thank you for partnerships in the community. I look forward to very important and timely discussions today, but also coming out today with what can we do working together to make this a healthier community and make this a healthier place. So thank you so much. And now I'm going to introduce, I don't think he needs an introduction, but Reverend Odell Cleveland will be facilitating and moderating our panel discussion this morning. He is not only a great colleague, but a great friend. I have learned so much from Reverend Cleveland over these past several years, understanding the community, understanding better health inequities, but also partnering to really make a difference. We've had the opportunity of working with him specifically, of working with several churches, including Mount Zion, really conducting health fairs, education, COVID testing, looking at ways to improve prenatal care in this community. So again, they're just a few of the things that we've done together, and I want to introduce Reverend Cleveland, and Reverend Cleveland, you take it away.
Again, good morning. You know, it's interesting when I get the pleasure to be Pastor Mitchell. We went to seminary together. He was my classmate, Bishop Brooks, and you know, he has that deep preaching voice, and we all would run there reverend quick to hear him. You know, in seminary, you have that certain time when you come and hear other preachers preach. So when preachers flock to get good seats to hear a preacher preach, that's my classmate right here. And I pick at him and says, you were the better preacher, but I was the better student. But with that being said, thank you all for coming. I see so many people here who's been in this struggle for a long time. Many of us don't just think, we know that the diversity and the inequities with healthcare in certain parts of the community, certain zip codes are real. And when someone asks the question, Odell, what's your why? Why do you care? Why did you get involved? Well, I had a situation as a child. My mother had a massive stroke, and she went to the hospital, and she was misdiagnosed. Now, anyone who knows anything about a stroke, Bishop, you know that seconds matters, minutes matters. Well, she was sent home, and the doctor said, well, you were just having paralysis. Well, she went home, and they said, come back, and this is the issue that's still with me after all these years. Come back on the free clinic day. Now, I don't know if that white doctor sent my black mother home because she was black and he was white. I will not go that far, but what I will know, by him misdiagnosing my mother, that has affected our lives and our family lives for the last 55 years. So we want to get to the point where we continue to fight the good fight for those who can't fight. Because it's easy to say that happened to her, but it happens to so many others who look just like her. So now, with that being said, I want to introduce the panelists, tell you who they are, and then one by one, we will start talking to our panelists. Okay? So as you know, you can read, so I'm not going to spend a lot of time. My good friend, Pastor Amos Quick, he's going to bring a different perspective because he brings a perspective of religion, but also of legislation. My mentor, Bishop George W. Brooks, the gentleman who nurtured me, who supported me, who sent me back to school to get my master's degree so I could be a better student than my classmate right here, all that stuff. And then he said, Odell, your master thesis is the Black Church response to the 1996 Welfare Reform Act. He said, listen, I like what you said. I need you to quit your job. I need you to do what you said you could do on paper, and I'm going to give you a year. And if you can't make this work in a year, I'm going to fire you. Thank you, Bishop. We have Dr. Derek Hoover, United Healthcare. We have another good friend of mine, Dr. Nanette Funderburg. I don't know why she married her husband, but that's a whole nother deal. He married up, so we're going to let that go. Keith right here. Dr. Lamont Williams and Reverend, this person who I'm just trying to build a relationship with because he's so talented, so powerful. The next Reverend C. Bradley Hunt, the president of NAACP for Greensboro Grant. Thank you for coming. Let me say something to you. A lot of people don't know who you are yet, but I know who you are, and I know your track record. and you just keep pushing. Because us old guys like us, we're gonna get out of the way, but we need you to keep pushing. Because the Amos Quicks of the world told me about you a long time ago, my brother. So you just keep being you. With that being said, let's go ahead and get started. And I shared my why. Today we will share in the Faith, Health, Equity Summit. We'll focus on key health equity topics affecting people of color and various perspectives: legislation, faith, community, physical, and mental health. So, Reverend Amos Quick. Reverend Quick, you're going to be coming up, and you're going to be talking from your perspective, sir, which is very unique, being a senior pastor, but also being a community leader, but also being a representative. And my questions for you is, why is health equity important from your lenses as a pastor and a legislator, and how health equity intersects with both the faith and legislative community? Pastor Quick, it's on you, sir.
Good morning. I greet you all in the powerful name of my Lord and Savior Jesus Christ, who I know is preached in this house and preached well by my beloved friend and the pastor of the Trinity AME Zion Church, Pastor Mitchell. I give honor to all clergy who are here present, including Greensboro's mentor, Bishop Brooks, and to all who are here representing clergy. Let me begin by apologizing for the need to have to leave immediately after these remarks to get to Raleigh, as we are in session this morning and we are voting on today. It goes without saying the importance of health care. Health is wealth, and that's an oversimplified but still powerfully true statement. If you don't have your health, you could consider yourself not to be wealthy in many respects. And there are many places where we could go. I say to Calvary Baptist Church, where God has allowed me to pastor for almost 10 years, that we can go to the hospitals and rehabilitation centers and find people who will give everything that they have to trade places with those of us who have some measure of our health. Right. It is important legislatively, and I thank God for Reverend Cleveland and his remarks in introducing me, because it is a marriage between the pulpit, the pew, and the community. And although we don't live in a theocracy, the church has a very powerful voice, and particularly in the black community, the church remains perhaps the most powerful voice to move people into action. Legislatively, it is important that we understand that what we do in Raleigh matters, and it matters to a lot of people. We are not just there pushing buttons to vote, but every vote has an impact on someone's life. And so there are legislative priorities that we have established. I'm a Democrat, I'm one of the Democratic whips, and one of the things that the Democratic Party, and I'm not being partisan here, but one of the things that the Democratic Party has pushed for a long time is the expansion of Medicaid. Over 600,000 North Carolinians do not have health care coverage right now, and the expansion of Medicaid, simply pulling down federal dollars that North Carolina pays to the federal government every year, just getting that money back from the federal government will do several things. First of all, as I said, it will cover 600,000 North Carolinians with medical insurance. Secondly, it will create, some estimates say, about 40,000 jobs in North Carolina, as the medical field, as you all know, is one of the fastest growing fields and a most necessary field of employment in North Carolina. In fact, Cone Health here in the Triad area is one of the largest employers. So there's an employment component to Medicaid expansion. It also makes sense that we expand Medicaid in light of the COVID-19 pandemic that we're still traveling through. It is amazing that we have almost 1 million North Carolinians without health insurance, and we're still in the throes of a global pandemic. I'm happy to say that my Republican colleagues on the Senate side have pushed forth a bill that would expand Medicaid to cover many of those 600,000, and hopefully that bill will make it over to the House that we can vote on it and support it. But not only the expansion of Medicaid is important, there are still some issues that we have had for years. Food deserts, particularly in Greensboro, here on the east side and the southeast side of Greensboro. I'm a lifetime resident of the southeast side of Greensboro, and I know firsthand, as many of you do, that there are places where there's no access to a grocery store, no access to healthy food, no access to the food that would sustain a healthy lifestyle. Instead, there are convenience stores that are high priced and sell many processed and sugary foods that contribute to the declining health of many residents who live on the southeast side of Greensboro. I never will forget, a few years ago, Pastor Mitchell, a story was done, I think it was in the News and Record, where they traveled with a young man who had to use public transportation to go to the grocery store. And that was an hours-long endeavor. And he could not get things like milk because it was spoiled. He could not get, if he wanted a treat like ice cream, he could not get that because it would spoil. His frozen foods would be under threat of being spoiling because he had to travel so far for so long and transfer from bus to bus just to make groceries for his household. That ought not be so in a state that has now a $6.2 billion surplus in funds. We also must establish healthy eating habits with our youth. Representative Cecil Brockman and I have put forth legislation. This is my third term, and if you'll continue to support me in November, I'll have a fourth term. But we've put forth legislation every term that would make breakfast and lunch free at schools. I just don't see that it makes sense that a child would not be able to have access to a healthy meal because of the poverty of their family. It's not the child's responsibility to pay bills, and we've shown in the pandemic, one of the silver linings around the clouds of the pandemic, my president, Bradley Hunt, NAACP president, is that the pandemic showed us that we can feed children for free. Right. Because remember, we were taking meals to communities and saying, everybody 18 and under, come get a meal. Whether you enrolled in a school in this community or not, come get a meal, come get something to eat. That's evidence that we can do that, not just in the midst of a global pandemic, but that ought to be the case every day. And summer meal programs are happening right now. Children are being fed right now with no regard as to whether or not they can pay for it. So Representative Cecil Brockman and I have thought that's been important throughout, and we should pass legislation that says school breakfast and school lunches will be at no cost. We can do that. We can do that, and we should do that, in my opinion. Finally, I'll close with just these other two areas of concern that we're pushing for in Raleigh. Number one is prenatal care. It wasn't until my oldest daughter gave birth to my grandson that I really had an awareness of how dangerous childbirth is and how important prenatal care is. Childbirth, particularly among African American and Latino women, leads to not only the pain of childbirth, but often it leads to death and debilitating illnesses afterwards. And that's something that in the richest nation on earth, that ought not be the case. We ought not be losing mothers in childbirth. And then finally, environmental racism. Brownfields in communities that have large populations of black and brown persons, which leads to things like cancer, which leads to things like other health concerns. We have to fight environmental racism. It was since I've been in the legislature that I've been made aware of the hog farms that exist down in eastern North Carolina. These farms are promoted to us as if they are family farms, but what actually happens is they are owned by international conglomerates who just pay local farmers to raise hogs. And as you know, an international conglomerate has one purpose: to make money, and to make money for its shareholders or to make money for its owners. And so environmental racism comes in that you have people living in eastern North Carolina who cannot enjoy the basic American right, which is to enjoy the fruits of your labor, to enjoy your house. We have neighbors in eastern North Carolina who can't have cookouts or family gatherings because of fecal matter being sprayed in the air and on their property. a study was done where some students from North Carolina State and Duke University went by and swabbed the tops of refrigerators and found inside people's houses fecal matter coming from hog farms and the spraying of hog waste. So I thank you for hearing me this morning, and I hope you heard that we have a lot of work to do, and that we have a work to do legislatively, and that we will continue to push so that every North Carolinian has the health, which is their wealth, to be responsible, productive contributors to our state. God bless you, God bless this house, and thank you very much.
Thank you, Representative Quick. We know you have a very busy schedule, so we definitely understand. This time we're going to ask my mentor, Bishop George W. Brooks, to come to the podium, please. Years ago, this individual, for whatever reason, took me under his wings, and he taught me, and he chastised me, and he closed the door and read me the riot act in his office and all the things that a young, cocky pastor needed to learn. He took the time to teach me. It wasn't always easy. It was a lot of tough love. You know Bishop Brooks, you know Bishop Brooks. You know, and I got an opportunity later on. He had a heart condition, and I talked with his wife. He was recovering, and I asked her a simple question, which we ask a lot of people: what can you do to help? And she said, you could walk with him in the mornings, Marcus. And I had the pleasure of walking and listening. Sometime as preachers, sometime as leaders, sometime as many of you are leaders, sometime we need to listen. I know we have all the answers, but sometimes we need to listen for the questions. So at this time, we're going to ask Bishop Brooks to come and share with us as leaders how to do self-care and why it's so important that we take care of ourselves. Bishop Brooks, the mic is yours.
Good morning. Thank you again, Odell. My wife told me to tell you that no matter what you did, don't embarrass me today. So I just thought I'd let you know that all was well. Certainly, we're honored to be here today. When I look over the participants today, I oftentimes wonder in cases where life is critical and issues are important, why fewer people show up until there's a crisis. Wow. I oftentimes wonder, what would we have done had not the pandemic come in terms of taking some self-time? I oftentimes wonder why it is that we seek not to change until there is a crisis. And the answer is simple. We go forward until something stops us, or at least slows us down. And today I want to talk from the perspective of dealing with a pastor who sets the tone and tenet for congregations and other leaders in the community. A pastor may be deeply committed, extraordinarily faithful, educated, extremely hardworking. But a pastor is effective and durable only if he or she practices healthy self-care. And self-care includes developing and maintaining good physical, spiritual, and mental health practices. Now, these three wellnesses are interwoven and they're inseparable. Oftentimes we put a lot of emphasis on the physical and the spiritual and forget the mental. But I can tell you, mental health includes our emotional, psychological, and social well-being. And unless the pastor or spiritual leaders are well themselves, how can they, as shepherds, lead sheep to green pastures that will keep them nourished? Very early in my ministry, and I come from a long line of pastors. My grandfather, my father, my uncle, all of those were pastors. And one of the things that was always in our family was we love sweets. I love sweets for appetizer, for the main course, and of course for dessert. But the truth of the matter is, it was literally killing me. Wow. And then one day, I was teasing my wife. She had gone on a Daniel fast for some 14 months. And I said to her, you know, God really must be upset with you, baby. You've been on this fast for 14 months. And my wife says, don't laugh, because I have a purpose. Some 2 weeks later, Dr. Mitchell, I got internal call from God, says, don't eat any more meats or sweets until I tell you. I have been a vegetarian for 39 years now.
Wow.
And I just started eating sweets about 3 years ago, and Lord have mercy, my tongue had vacation and went into a convulsion and some other stuff. So I want y'all to know, don't send me any sweets. But at any rate, part of what happened in the early parts of my ministry, our members would bring lots of cakes, pies, and I was a banana a pudding person. I made banana pudding for the whole church at times, and I love those sweets. So my wife says, after that encounter, don't be making my husband fat, bringing him all of this sweets, because I want to keep him around a few years. Of course, I did not listen as I should have, and I had a heart attack, had 5 bypasses on the way to pick up my daughter from college, and by God's grace, I was able to get to Chapel Hill, and of course, I had to have surgery, and all is well, and that happened in 1994. I think I'm doing pretty good some years later now that I can do all the things. I was with my personal trainer the other day, and he said, at 75, Pastor, you do a lot of things people at 56 can't do. And I said to him, the reason is my wife made me do all this other stuff in the interim, so that's why I'm here able to do what needs to be done. But let me stay with mental health. Every human being experiences high and lows in mental health. And although some forms of mental illness are genetic, other expressions of mental illness may be related to circumstances or body chemistry and may be preemptively avoided if in fact we know and recognize and acknowledge that there is a problem. A common but naive misconception is that pastors or persons with strong religious faith are exempt from mental distress. The Apostle Paul noted, for his courageous ministry, said, besides everything else, I face daily the pressures of my concern for all the churches. The pastoral task requires remarkable investment in the lives of others, and a pastor who neglects mental hygiene can gradually slip into states of melancholy or emotional chaos, and then compound the dilemma by ignoring the symptoms for fear of being stigmatized by his or her ministry followers or his congregants. I have observed that at least there are about 5 areas that affect pastors as it relates to their overall self-care. Number one, there's unrealistic expectations of religious leaders. These expectations can be perceived, or they can be generated by vocal congregants, or they can be self-imposed, with the ministers thinking that they have some kind of messianic complex and they are a god of a sort. Wow. And with most congregations, midst of exceptions exist, and they fluctuate between market-driven goals, that we have, things like budgets, denominational recognition, progression in the line of offices, the mission-driven goals like transformation, ministry participation, stewardship practices. We're expected to do all of that and still be balanced.
Wow.
And the wider the gap between our mental well-being, our physical and emotional well-being, determines how and what kind of legacy we will leave for those who follow us. I have a statement that I carry with me all the time. When I die, I want to die empty. I do not want to carry to the grave anything that can help someone left on the earth. If we would take the concept of dying empty, Give all you got that God has given you with a gift you have. So you don't have but one gift. Give 100%. So you have 5 gifts. Give 500%. The key is we're here not by accident, but we're here by providence. And based upon that, there's nobody on the planet Earth can do what God has assigned me to do. And so I should do it with my best efforts. Many professional public speakers have 4 or 5 mixed speeches, and they go over and over to different groups, and professors and teachers have lectures and lesson plans that are updated and revised from semester to semester. But they usually follow a core curriculum. But a preaching pastor is unique in that he or she is generally expected to prepare and deliver 40 to 50 different Sunday sermons per year, virtually to the same group of people, in addition to devotional, Bible studies, funerals, and other community speeches. 40 to 50, I guarantee you $1 to a burnt peanut. If I preach the same message 2 Sundays in a row, I'll get all kinds of emails saying, what in the world are you trying to prove? Didn't we hear that last Sunday? Wow. Then we have a plethora of emotional encounters. A minister deals daily with grief, grace, and everything in between. Perhaps more than any other vocation, a pastor regularly moves in and out of situations with polarizing and oftentimes intense emotions, such as death, birth, divorce, marriage, perversion, conversion, conflict, and resolution. And all of this can happen in one day. If a pastor is not careful, the residual emotions from these encounters will linger and intermingle, creating either emotional apathy or neuropathy, one of the two. So then there are problem people. Now I need you to understand there's a difference between problem people and people with a problem. We can handle people with a problem, but every now and then we encounter some problem people. Problem people are usually high maintenance, who consume an exorbitant amount of a minister's time with petty complaints or unconstructive criticism. And they often say, or have said to me, I don't know if they say that to Dr. Mitchell because, you know, he has more stature here than me. But at any rate, they say to me, if I were you, now if you were me, you'd do what I do. Amen? Okay, all right. So then, you have to deal with that. One writer called problem people well-intentioned dragons who breathe out fire and expect to burn everybody in their path. Then, of course, there's a whole confidentiality piece. We are expected and should be confidential in the information that comes to us. We have to deal with that, and we have to separate that from our personal lives and from those who trust us. Perhaps the worst thing that can happen in the life, as far as I'm concerned, of a minister is for his congregants and the people in his community to lose faith in him because of the lack of integrity. Integrity is high on my list. There are a number of things I have not done and would not do, not because I'm so good, but because it would in fact affect and in some cases poison my integrity. Mercy. I refuse to go along with the crowd just because it's popular. If we as pastors will take these things into consideration, then we can lead our congregations to eat well, to run well, to think well, to pray well, to live well, and we can have a better community in the world. Thank you.
Bishop Brooks, thank you again for all that you do and all that you will continue to do for this community. At this time, we'll be asking Dr. Derek Hoover, MD, to come up And Dr. Hoover is the medical director for the United Healthcare Community Plan in North Carolina. Okay, Dr. Hoover. Okay, good. Dr. Hoover is a family physician with an extensive background in various clinical settings. Question for Dr. Hoover is this. Dr. Hoover, you have years of experience working with patients. What makes United Healthcare unique and special for the African American community? Key health issues impacting African Americans, value of managed care, shared success stories. So Dr. Hoover, we welcome you and we thank you. And now we need to hear from you.
Good morning. So it's going to be hard to follow the speakers that we had already this morning with the power and the force of words. I'd like to start with something that I heard. Well, first of all, I was told I had 5 minutes, and 5 minutes is not enough time to go through some of these topics. I'm going to use some notes here. But wanted to start off with, I heard health is wealth, and that's something my grandmother told me growing up, when I was very little. And then the other thing I heard wasn't said in these words, but you are what you eat, right? And we talked about food deserts and you know, high intensity, high calorie foods and how those can affect people. So prior to coming to United Healthcare, I led the healthcare for the homeless as medical director for healthcare for the homeless in Raleigh, and so worked with a lot of patients that had medical problems and that were in underserved communities. And you know, if you think about the food that they get, right, it's processed foods, high calorie foods that people hand to them, and so it's hard to be healthy, you know, with that. So to start off with, I'll share a quick story about a patient that we worked with recently. And because of HIPAA, I'm going to be intentionally vague about the background. But this is a middle-aged man experiencing homelessness with a history of diabetes, hypertension, hepatitis C, cirrhosis, and COPD. He had been to multiple emergency rooms, admitted multiple times for care. Had issues with housing, and so kept getting discharged to people's couches, to the streets, to hotels. And the last visit, he was discharged to a hotel with 2 days worth of hotel bills paid. So as part of United Healthcare, I work with the care management team and also with the inpatient management team. And so this gentleman was being admitted at different areas, so in different counties and different hospitals, and so it's hard to pick up that there was a problem going on. One of the advantages that I have working at a healthcare organization such as United Healthcare is we have access to information, and one of the big problems with healthcare now is everything is so siloed, right? You know, the right hand doesn't know what the left hand is doing, the left hand doesn't know that the right hand exists, right? And so it's really hard to move forward and help people navigate this convoluted system when it's hard even for me to navigate myself sometimes. So one of the services we provide at United Healthcare, we have a very engaged care management team, and so community trust relationship are big pieces, right? And I think our care managers are able to interact with people, understand what it is they need, and help connect them. So this gentleman kept getting discharged and kept going back to square one. So it was just a vicious cycle, and his health was getting worse and worse as we go forward. But luckily, we were able to identify him as someone that needed help and help him navigate the convoluted system. In building that relationship and trust with the care manager, we found that he was having cognitive dysfunction, meaning that his memory was failing him at a young age. And if we look at diseases like diabetes, hypertension, higher risk of strokes and vascular dementia, right? And so he's been set up for failure throughout his life. We're able to work with the community, with local community-based organizations to help find help for the hotel room for a few nights, and eventually now he is stable and admitted at at a skilled nursing facility and will stay there for the rest of his life, and very, very happy with the outcome. And kind of just throwing some numbers to the statistics. I know Anita and others have spoken today about the impacts on the African American community in regards to health disparities. But just to throw some numbers on there, Black women are 3 times more likely to die from pregnancy-related complication. 3 times more likely, which is unacceptable. Between 2014 and 2018, Black women were 40% more likely to die from breast cancer, despite rates of diagnosis being the same among Black and white women. African Americans are 50% more likely to have stroke than white counterparts, and Black men are 70% more likely to die from a stroke. African American women are twice as likely to have a stroke. Same, we can keep going on and on and on and looking at all these diseases. So I'm a family physician, primary care physician, and so I started my career initially in general surgery, and then quickly realized the importance of preventative medicine, right? And so we would, take out colons for colon cancer, do mastectomies to help diagnose and treat a condition. But as we continue to do this, you realize the suffering that happens with that, not only from the diagnosis, not only from the pain of surgery, not only from the recovery, and then the family and lost income, and then healthcare bills, but from the suffering that goes on with these individuals that undergo these procedures. So I was called to do something more, right? And I think the big key, prevention, I've heard today as a common topic as well, right? If we can prevent problems, that we can prevent suffering. And so I was called to family medicine, which focuses on preventative medicine. So if we think about diabetes and hypertension, right? So, I explain to patients that with blood pressure, right? So your blood vessels are only capable of taking a certain pressure in them. And as your blood pressure is 120/80, your blood flows through your blood vessels with no problems, right? As we start going up in blood pressure, you start having more friction on the blood vessel walls, causing inflammation. If you throw in sugar, which occurs with diabetes, into this, you have inflammation, really sticky area, you throw in cholesterol, you end up with plaques. And that doesn't just stay in the heart or the brain, it goes all over the body, right? And so I think part of the importance of this collaboration and this communication is impactability and prevention. And I can talk to patients that come in front of me on a day-to-day basis, but the people that need to hear it may not be coming in front of me, which is why it's important, I think, that we work together as a community to help prevent some of these preventable problems and prevent suffering in our communities. Thank you.
Dr. Hoover, thank you. You made me think about my mother when you talked about caring for people. And I wish you were the doctor who saw my mother instead of the one who said, come back on free clinic day, even though my mother had insurance. So as we asked Dr. Funderburg to come forward, a lot of times we have insurance, a lot of times we have, and I'm speaking to the statistics, a lot of times we have what other people have. It's just that a lot of times on the port of entry, we don't get treated the same. That doesn't really show up in statistics. The results of not getting treated the same shows up. But the biases, the prejudices, the stereotypes that's associated when we come through the door is somewhat different.
Right.
Dr. Funderburg, my good friend. Dr. Nanette Funderburg is a psychotherapist. Couldn't spell that in the spelling bee, but it's okay. And owner of the Social and Emotional Learning Group, a counseled private practice in Greensboro. Dr. Funderburg, your question will be, our community has experienced a pandemic and more recently increased gun violence in multiple settings. Help us understand how mental health is impacting our daily lives. Important in reducing the stigma in mental health. Because when I grew up, black folk didn't go to what we call the shrink. We don't go sit, we didn't do that. And I'm old school, so I'm still understanding the importance. But when I grew up in South Carolina in Geechee, black folk didn't go see a shrink. Black folk didn't go and see a shrink. Dr. Funderburg, can you come please and address us? Thank you.
Good morning. Good morning. I'm so glad that we have folks here today, and am I supposed to be looking at my time up here? I'm gonna try to keep that in mind as well, because just like Dr. Hoover, I'm like, we could talk all day on these topics. I think each person who's been up here could have a day to speak about what it is that their topic was. So I'm going to try to be brief. But I do have my PowerPoint up here, so I'll go ahead and ask you to advance the slide. So for those of you who can see the slide up here, can anybody see what that says? Yeah. I'm fine. That's how we answer the question, hey, how you doing? I'm fine. Oh, I forgot we're at church. That's not how we say it at church. How do we say it at church? How you doing? I'm blessed and highly favored. Exactly, that's what we say. But you just got that diagnosis. You just came from the house and your husband who left his socks on the floor had just gotten on your last nerves. I won't look over there, y'all. I'm not gonna look over there. You know that you were frustrated with a job issue or whatever the list of things might be. But somebody asks you how you're doing and you say, I'm fine. Or if you're at church or you're at choir rehearsal or you're at Bible study, you say, I'm blessed and highly favored. I'm blessed of the Lord. Right? That's how we do. I get it. I totally get it. But let's look at this I'm fine a little bit closer. I don't know if you can see this, but there are some words that make up this I'm fine. The fine is made up of other words, and it says I'm worried. I'm depressed, I'm terrified, I'm feeling useless, I'm unable to work, I'm stressed, and on and on and on. But still, somebody asks you how you're doing, and you say, I'm fine. We are not fine, and until we acknowledge that we're not fine, we're not going to be better. So this is a part of how mental health impacts daily life, because we have these mental health symptoms, but we're not acknowledging them. We're acting as though nothing is wrong. We're acting as though we're fine, and we're really not. So let's keep going here. Sometimes I think, people are scared of mental health. We think somebody's gonna call us crazy. We think somebody's gonna lock us away. And while there are mental health issues that do require someone to be in a facility, the majority of mental health issues, that's not the case. Has anybody in here ever been stressed? That's a very basic mental health issue, because where does the stress occur? The stress occurs up here. It's not in the issue. The stress is in how you perceive the issue. So that's about your mind. That's up here. That's a basic mental health issue. 1 in 5 people has a mental health issue. So mental health is not something to be afraid of. It's actually something that is impacting you every day. It's just how big is it going to be? How much is it going to happen? It can come to you like a cold, which we can take some over-the-counter cough medicine and get rid of it, or it can come to you like the flu, or it can come to you like pneumonia that potentially could require hospitalization. Okay? All right, let's keep going here real quick. And so when Bishop Brooks was talking, I said, did you see my presentation? I mean, he was saying some of the same things, and I think this is just a sign to us of how much this stuff overlaps. Oftentimes when I see people, we have people of faith who come into our practice, but they don't come at problem 1 or problem 2. They come at problem 20 or problem 25 when it's been overlapped, and it's just, it's a much bigger issue. But, I might call it cognitive behavioral therapy. Those, if we're reading scripture, we're going to say, as a man thinketh in his heart, right? So is he? It's the same thing. It's the same thing. So I wanted to highlight that we're saying some of the same things, and we can't be afraid of addressing these issues when there is so much overlap. So mental wellness includes our biological, psychological, and social well-being. That's the whole person, y'all. That's the whole person. Let's keep going. It affects how we think, feel, and act. If you want to change how you're feeling, you have to change what you think. You have to change what you think. So if you're unhappy about a situation, we can make a choice on how we're going to think about it. That's what the advertisers do. They tell us how to think. They tell us, here's the new chip, buy the new chip, eat the new chip. The new chip is great. The next thing you know, you go to the grocery store and you see the upfront kiosk with the new chip, and you say, you know what, let me try that new chip. Not because you really wanted it, but because they told you to. You can insert the thought that you need to think, and it will shift how you feel. It will then shift how you act. Let's keep going. It also determines how we handle stress and relate to others and make choices. So let's go maybe a couple slides further, because I know I need to move quickly. Go to the next one after that. You're going to have to click through all those bullets there. Sorry, sir. Okay, this one is talking about the Adverse Childhood Experiences Study. Anybody ever heard of that? Okay, good. I'm glad some of you have. Or ACEs for short. There was the CDC's Adverse Childhood Experiences Study uncovered a link between childhood trauma, i.e., some of the stuff that the folks up here were already talking about, having the food deserts, not being able to eat, having other forms of toxic stress, uncovered a link between childhood trauma and the chronic diseases that people develop as adults. So wait a minute. Not having food to eat, or just being super stressed as a little person, 18 or below, can determine if I have lung cancer when I grow up? Yes. It can determine if you're depressed when you grow up? Yes. Let's keep going. So these were the adverse childhood experiences in the study. There were 10 of them, and listen at how common these are, y'all. Physical abuse, emotional abuse, sexual abuse, physical neglect, emotional neglect, mental health issue in the family, having an incarcerated relative, if you saw your mother or stepmother being treated violently, someone in your family used substances, or if there was divorce. Can you think of anybody who has maybe one of these? You can probably think of a lot of people who have a lot of these. So that's what the study showed. When these things happen below 18, it can determine whether you have heart disease, lung cancer, autoimmune disorders, depression, all sorts of things later on in life. There is a link between all of this. So this is how our mental health is impacting our daily living. I think go to one more slide. The child may not remember, but the body does not forget. That's what, there's a book called, hopefully it'll come to me before I walk down from here. But there's a book that discusses exactly that. Lots of times kids don't remember. We don't remember everything that happened in our childhood, but our bodies encapsulate this trauma. And if we don't do anything to express it, i.e. get rid of it, then it's just in there. It's stuck in there. When those stress hormones come out, we get bathed in the stress hormones. Our developing organs get bathed in the stress hormones. Kids can't grow healthfully that way. One more, I think. Keep going. Yes, this is the one I wanted. So you get an A score so you saw those 10 that I had up there. If you have one of those, your A score is 1. If you have 5 of those, your A score is 5. You get it? So if you have 2 ACEs, you are 2 times as likely to develop heart disease. 4 ACEs, 3 times as likely to suffer from depression. 6 ACEs, y'all listen, 6 ACEs, or 6 plus ACEs, 20 years lowered life expectancy. This is how mental health is impacting our daily lives. We have to do something about it, and I can't remember which person said it, but again, we were overlapping. How do we do this? We've got to address our biological, psychological, social, and spiritual areas of our lives. We have to address ourselves in those 4 areas preferably every day. If not every day, hopefully multiple times a week. I know I got to go, but I hope you all have learned something from what I've brought to you today.
Dr. Funderburg, thank you. I always thought that your husband married up. Now I know for sure that your husband married up. The child may not remember, but the body will never forget. That's interesting from someone who could be the poster child for what you're talking about. At this time, we're going to ask Dr. Lamont Williams to prepare to come, please. Dr. Williams is let's make sure I read this right. Dr. Williams is the Faith Engagement Director of the Maya Angelou Center for Health Equity at Wake Forest School of Medicine. But the interesting thing about it is this. He's a pastor at Bethlehem Baptist Church in Warrenton, North Carolina. And the fact that pastors deal with so many things, and there's a difference between an urban pastor and a rural pastor. It's the difference between a pastor of 1,000 members and a pastor of 7,000 members. It's just a big difference. And Dr. Williams, we're going to be asking you that how can local pastors and community leaders engage their community effectively to address health equity? And what's the critical role community engagement plays in promoting health equity in historically marginalized communities? Dr. Williams, can you come and share with us, please, sir? Thank you.
Let me say good morning to all of you, my friends and certainly colleagues. I call Dr. Mitchell my friend. If I sat down then, I would be sufficient because he has demonstrated what true friendship looks like even in ministry. I want to open my dialogue today by talking on the subject, the why to Black reticence to medical partnerships. The why to Black reticence to medical partnerships. I want to start my discourse this morning by talking about a recent conversation I had with a Black gentleman less than 30 days ago. We were talking about Black men's health, and he indicated that he had a PSA score of over 1,000. Now you do know that particularly 7 and unders is alarming within itself. And this Black gentleman had went to a white physician, and he told him that he was concerned because his PSA was too high. The white gentleman returned the conversation back that, oh, I see people all the time with well over 1,000. You have nothing to be concerned about. He spoke to a Black physician who encouraged him to contact the medical board for just egregious medical advice. It is some of what I want to talk about this morning. A partnership in the community. I start by saying that my director, Dr. Goldie S. Berg, who heads up the Maya Angelou Center for Health Equity at the Wake Forest School of Medicine. She's been very intentional about raising awareness on health equity. One thing we can tell you is that she has been very phenomenal. I love this and I talk about it all over the country. She argues that there is a difference between trust and trustworthiness. The reality is that the old paradigm puts the onus on the receiver for the trust. But the new paradigm puts the onus on the giver, and you have to answer, have I earned your trust? It is a new paradigm when we begin to consider just how important the word trust is in our relationships in the community, certainly in our medical relationships as well. There's another term that I have come to really have a passion for, and that is another tenet, which is asset-based relationships. That is simply to argue in the old paradigm, typically the medical community comes to the marginalized community and they argue that you have a deficit. I want that to sit for a moment, that the reality is the only reason why you're there is because the marginalized have a deficit and you're coming to speak to the deficit. But I want to argue today that there is a new paradigm and it's called asset-based relationships. That is simply to say whether you're in the country, whether you're in the city, whether you're big or small, everyone has something that they can bring to the table in the partnership. For I submit to you that even with the PhDs that we have in medicine, when I come into Trinity, all that stops at the front door. Yes, because I too become subject to the servant leader of the house. And it's important for us as in the medical community to understand that when we're dealing with marginalized communities, they many times have assets that we might not have thought about. Can I give you one? It's called being the gatekeeper. The gatekeeper is the person that you must deal with in order to get behind the wall to those who are marginalized. And so it is something that I argue all the time. And then thirdly, in this partnership is a new term I call acknowledgement, past and present. For so many times we come in the medical community to our marginalized communities and we act like there has not been any atrocities. And when I tell you it is a game changer, because many times, whether you say it publicly or not, it is the big elephant in the room. And I tell you there's nothing any more dismantling to a medical relationship than to act like things did not happen. And what I say is, listen, I want to talk about how this impacts health equity. There is this, I was in Denver the earlier part of this year, so glad to have attended. It was a National Alzheimer's Association meeting, and in the meeting, Dr. AME taught and gave a presentation on socio-economical health disparities. And she said to the medical community, it is finally time for us to acknowledge that these socio-economical challenges impact health equity. For example, when people are poor, when they have transportation barriers, these things have access and impact on health equity. And I was so glad to hear. I knew it all the time. I've seen it through so many people. Listen, how you come up in school, the environments through which you have food deserts. These things all impact our health equity. And so then I want to close my time with you today talking about medical mistrust. I want to offer a resource to you today that has been impacting and informing my work. I just came from Providence, Rhode Island, just last night, speaking to hospitals there struggling with medical partnerships. And one thing I have left there as I leave with you today is a resource called Medical Apartheid. You would be well served to go and find this resource. The author is Harriet Washington, and she argues in her book about the intentional misrepresentation of African Americans' contributions to medicine. Because what she says is when you write African Americans out of medicine, you also build on that atrocity. She raises an example in the book about a black slave who ultimately trains the first white medical doctor on the first vaccine. I want to suggest to you, but the slave is not in the medical books, but the white doctor is. And what she says is, when you write them out, it builds on the medical mistrust. She also says that in the book, I want to ask you, as those who have been marginalized, to get involved and find a physician that looks like you, because that physician can advocate for you in spaces that you as a participant might not be able to be in. My time is just about up, but I want to tell you that she says that if we don't get involved, then we will marginalize ourselves all over again. I want to suggest to you that the National Alzheimer's Association says that African Americans are only 5% represented in research studies and programs. What that means is that when studies and cures are developed, my friends, it will not represent the marginalized community because they won't have the data for us. I say to you that this statement that I leave, Dr. Mitchell, it is time for the medical community to realize that we, as African Americans and marginalized communities, should be at the table and not on the table. For far too long, we have been excluded from the conversations. And can I tell you something? I was in a recent meeting with some leaders, and they were talking about how to impact those marginalized homeless people. And finally, one pastor stood up and he says to the leader, I won't call his name, he said, Mr. Leader, I want you to look around this room. And I want you to ask the question, can you ask the homeless person to stand? It was a staggering observation that many times we try to fix the people without bringing them to the table. God bless you.
Dr. Williams, powerful words, my friend. Very, very powerful words. At this time, we will have Reverend C. Bradley Hunt, who's the president of the NAACP Greensboro branch, come forward. And we're going to ask Reverend Hunt, what is the health desert and what is his thoughts? Because he's a young man. When you get my age, everybody's a young man. Bishop Brooks, you know, he's a young man. And I love to see young men get their opportunity to do what's right and to lead. And again, as I stated earlier, I found out about this man years ago, and I've watched his career over the last couple of years. And so I'm very proud of all that you're doing. Reverend Hunt, it's on you, sir.
Thank you, Reverend Cleveland, and good morning to each of you. Certainly we honor God preeminently, and we are grateful for this opportunity. To Reverend Cleveland's point, oftentimes young people don't get an opportunity to express ourselves, and so any opportunity that we have to share is greatly appreciated. I thank you, Dr. Mitchell, for the invitation, and I'm certainly encouraged by this partnership, United Healthcare. I want to elaborate on the discussion that Dr. Williams has started and really speak to how I feel the socioeconomic conditions, how they impact health equity. To Dr. Funderburg's point, these issues overlap and are interconnected, and so it's difficult. It's a challenge to stand here and to try to address all of them, but I believe as a young person and a young leader, I lead the NAACP here in Greensboro, it's important that I'm able to focus on one issue. Bishop Brooks, you said that oftentimes leaders take on this messianic approach to leadership, trying to solve all the issues, and I'm here to tell you I cannot solve all of these issues, but I do want to give space for some discussion. But I do challenge us not to allow this opportunity to become an exercise in futility. I believe that discussion is good, but discussion without action is disgusting. And so I challenge us to move beyond this space and look ourselves in the mirror and tap into that personal commitment that says that we must do something about what we are discussing today. And so, as I said, ultimately, we need, in Greensboro, across this country, we need access to high quality, affordable health care. We need access. My predecessor with the NAACP, Dr. George Simpkins, started this journey back in 1963. I know some of you who are longtime residents know Dr. Simpkins. And he started this back in Simpkins versus Cone when he sued Cone Hospital because they would not allow black patients to come in. We had L. Richardson Hospital here, but that was for blacks, of course. It was antiquated and not suitable, and certainly not on the level of the other hospitals, notably Moses Cone and Wesley Long. And so Dr. Simpson said, we need to do something about this because these hospitals, in particular Moses Cone, Wesley Long, are receiving federal funds. And if they are receiving federal funds, then we should have the same equal protection under the law as afforded to everyone else. And so we need access to these hospitals. And ultimately, he won this lawsuit in the Fourth Circuit Court, and we saw where there was an integration and where blacks were allowed to come into these hospitals. But what we see in Greensboro today is so disturbing because we have the de facto segregation in our health care. Make no mistake about it, de facto, actual, existing segregation. It's true in fact, but it is not officially sanctioned. It's de facto, it's actual, but not officially sanctioned. And Jim and Jane Crow laws were perpetuated by de facto segregation, de facto healthcare. What do you mean, de facto healthcare? That means that communities of color have no health care, while other communities have excellent health care. Communities of color have no health care, while other communities in the same locale have excellent or phenomenal health care. One large healthcare provider, that's a nonprofit here, has revenues of $2.5 billion a year. In Gifford County, when you compare whites with blacks and look at the death rates, it is higher for blacks when considering conditions of cancer, heart disease, strokes, and diabetes. Here's the interesting aspect. When you look at a map of Greensboro from the 1930s, you can see the communities that banks would not give loans to. We've come to know this as redlining. What's also interesting about redlining is that you also can see who they gave loans to. Green lining, yellow lining. If you look at that map, you see that the map of the 1930s is similar to the map of Greensboro in 2022. The life expectancy in East Greensboro, 65 years old, 72 to 72 years old. But as you go further west, that life expectancy increases to 82 to 87 years old. There is a 18 and a half year gap in life expectancy when you live in East Greensboro as opposed to West Greensboro. We've said this for years. We live in the tale of two cities. COVID-19, East Greensboro, higher rates of infection. South Greensboro, higher instances of COVID. The death rate by COVID, higher in East Greensboro, higher in South Greensboro. The largest healthcare provider in Greensboro, if you look at those communities where the median income is $39,000 for a household of 4 people, it aligns with red-lined communities. These issues, yes, are interconnected, they overlap, and socioeconomic conditions are at the root of health equity. Would you believe that even today in 2022, in the basement of one of Greensboro's largest hospitals. It is still there that the internal medicine teaching clinic is located. In 2022, you all remember during Jim Crow, medical facilities for blacks were in the basements. Black people couldn't go through the front door of the hospitals. They had to go down to the basement or in the attic or some other location on the campus of the hospital or elsewhere. What I'm trying to get you to understand is we have a long way to go. We want to believe that we are progressing, that everything is all right. And I know we've heard a myriad of issues today, but it is going to require us to look at this from, yes, a historical standpoint. Because if we do not know where we came from, there's no way that we can even fathom where we're going. The Affordable Care Act gives some space for us to deal with this because I believe in solutions. The Affordable Care Act says that community health needs assessments for charitable hospital organizations should take place every 3 years. That the hospitals should look, what are the needs of the community? And every 3 years, hospitals should conduct these assessments. Hospitals should adopt an implementation strategy. We need residents and those like you who understand that this is a very serious issue to join in on and be representatives on these boards that conduct these health needs assessments. Because oftentimes in government, we do studies, we do trainings, we do these assessments, and we get the recommendations, and we do nothing with them. In 2019, the executive summary was printed and posted, and it revealed that the #1 issue in Greensboro as it relates to health equity is access to high quality, affordable health care. The reality is, when you look at the map of Greensboro today, and you look at the map of Greensboro of 1930, we have no healthcare facilities in our communities because those same communities were left out in 1930. They're being left out in 2022. I'll close by saying this, if you don't believe this is real. Just recently, in Northeast Greensboro, a $100 million healthcare facility was built. 3 aquatic swimming pools connected to a YMCA with a gymnasium. $100 million investment, while the people in Southeast Greensboro and South Greensboro have no access to adequate health care. I challenge us today to gain and to garner moral courage that says that no matter what anyone else says, no matter what others think about me, I am going to stand up, I am going to speak up, and I am going to let my voice be heard on the issues that matter. Thank you.
Reverend Hunt, it's just amazing, as I stated earlier, a lot of people don't know you yet. Yet. But please, sir, continue to keep pushing and continue to accept. Yes, sir. Continue to accept invitations when given, because this is a community issue. It's a community problem. And we need your voice, sir. We need your leadership, and we need your understanding. Everybody may not have Bishop Brooks, who mentored me, but I know you have mentors. At this time, we want to thank our panelists, and we're going to take a few questions, and then we're going to take a break. Please, ma'am, please, sir, during the break, you can go up to the panelists and talk to them, do everything, but let's continue to practice social distancing to a point, because believe it or not, COVID is still here. Can I take 1 or 2 questions? Anyone has a burning question, or anyone just need to go and take a bio break? Where are we? Okay. Hearing no questions, I'm going to ask Bishop Brooks. Bishop Brooks, can you share with everyone what you've gotten from this service? Because you're the, not elder statesman, you're the wise wisdom guy here, Odell mentor.
Well, I didn't pay you enough. You didn't use enough adjectives.
Yes, sir.
Well, certainly out of this, as I sat here and listened to the statistics, as I listened to the presentations, as the questions were asked, I thought perhaps the one sentence that impacted me most was discussion without action is disgusting.
Yes,
And certainly we need to act. We heard from the professor and others about what's transpiring. So the question gets to be, now that you've heard, what were you going to do? And so for me, I was just sitting here thinking how I can get involved. You know, if I get involved with a young man, that'll make me feel young. So the issue is we can't just have seminars and gatherings, go home, and business remain as usual.
Yes, sir. Thank you. Any other thoughts? Ms. Alexis? Yes, ma'am.
I was just gonna ask if
Do you mind standing up, please? Can someone get her a mic, please?
I can talk loud.
You can talk loud, but we can't always hear loud. So we're good. We're good. Thank you. We're good? Good. Thank you so much.
So, can you hear me?
Yes.
So I was invited today by Pastor Odell to come to this event, and I'm grateful for the opportunity. But I wanted to just challenge the people that are here today. In my role at Caregiver Connect, which is a nonprofit organization that was primarily started by Mount Zion Baptist Church to serve family caregivers, I do absolutely agree with what you all said today, but in so much of what we've talked about, there's a patient, but there's also a caregiver who's helping the patient to get to every appointment, to get to the hospital, to then carry out the care that you expect to take place. And so often, I don't want us to leave this session without considering the caregiver. And it shouldn't necessarily be patient-centered care. Maybe it should be patient and caregiver-centered care. And that if we could get the insurance companies to also buy into the importance of caregivers and what caregivers bring to this. And so often if we could get the caregiver to not be working so hard to get to the grocery store, to get to CVS, to be able to take a minute to do self-care, good things could possibly happen to benefit both the patient and the caregiver. So I just didn't want the panel to leave today without considering not only the person that we're so focused on, which is the patient, but we should also be concerned about the caregiver. Because so often the caregiver is the reason the patient is benefiting or trying to benefit from their service. And the patient requires the caregiver to be the advocate for them. And we all need to be an advocate for each other. And I didn't want the time to go away, Pastor Odell, without mentioning that caregivers are important, and caregivers are important in this conversation. That if you can show value and that you value the caregiver as well as the patient, perhaps better things would happen and we could make some progress.
Good. Thank you so much. Well said. Can I call on Rabbi? Do you have a comment? Oh, I'm sorry. I didn't see. I apologize. Yes, can we get the young lady a mic, please?
Thank you. I'll use my preacher voices to be here. Thank you, Bishop.
All right.
I am so glad to be here today. I am in partnership with several of the people that are on your panel and that are visiting today with Duke Hill and Wake Forest and Dr. Mitchell and I and Bradley, your man. I love it. I want to say a couple of things. I pastor right in East Greensboro, St. Philip AME Church, right down the street. We have a community garden there, helping our people in the community. I want to challenge and ask United Healthcare. I spent 9 years working for an insurance company. I'm not going to name it. I'm going to challenge United Healthcare to not only hear this, but to go to your leaders and make a difference. We need you to make some changes. And I'm going to be a personal example today. I'm diabetic, had wonderful insurance while I was working. My husband retired before I got old enough to get any other type of insurance, so I was one of those that had to figure it out. Affordable health care. Yes, I got a low premium, but my deductible is over $10,000. I don't qualify for Medicaid. So where does that leave us? It leaves us going to health care organizations that are still saying no, because you already have a problem. You're diabetic, you have disease. Healthcare, health insurance companies, please, please start making a difference. Thank you.
Have Deborah join the Medicaid program in October of 2016. She was a member of the Transformation Design Team and was later appointed to Chief of Staff, providing support to the Deputy Secretary on the overall program and the vision for North Carolina Medicaid. Several of her biggest priorities during her tenure as Chief of Staff was to address equity in hiring, career advancement, and health equity policies, especially for historically marginalized communities. Are we able to hear Ms. Barrington? Fantastic, Deborah. Turn it over to you. Thank you for your time this morning.
Thank you all, and I appreciate your patience. So I wanted to talk to you just briefly. I know that we lost a little bit of time because of the technical difficulty, but talk a little bit about how North Carolina is addressing health equity for North Carolinians. I want to talk about why we're focusing on equity, what we're going to do to move forward, and what you can do as key takeaways. Let me just say that when I joined earlier from another meeting, I heard, I think it was Reverend Hunt and others talking about the incredible need that you have in Greensboro and the lack of access to health care. And I just want to echo that that is a situation that we're experiencing across the state. And you all, many of you may know that there is a bill before the General Assembly right now to expand Medicaid. If we were to do that as a state, then there would be approximately 600,000 people in the state of North Carolina that would be able to get access to health care. So in addition to the call, I heard a young lady make a call earlier to United Healthcare about sort of carrying the message forward and doing all that they could to address health care. I would echo that call and sentiment to you as leaders, as pastors, as members of the community. I think reaching out to members of the General Assembly and let them know that you are in support of the expansion of Medicaid, if that's the case. We know that that's a key priority for the state. It's a key priority for the governor, and we would welcome any support that you can offer for the expansion of Medicaid, because we have hundreds of thousands of people, many people of color, many people who are historically marginalized who need access to health care, and without it, we'll continue to lag behind as a state in being able to address the needs of North Carolinians. Let me just talk a little bit about some things that I believe that you all know well. I know that there was a FEMA center established in Greensboro, I think at the mall, that was focused months and months ago on making sure that people got immunized, got the vaccine. And the reason for that is because what we saw was that COVID had a disparate impact on historically marginalized populations, especially people who are Black and brown and those who have chronic health conditions. I heard someone speaking earlier today about diabetes, and that is one of the many health conditions, heart disease and others, that we experience in high rates in our communities. And COVID exposed that problem. COVID, as we know, did not create health disparities, but it certainly shined a bright light on the inequities that we experienced in our system. We saw people who were historically marginalized had higher rates of contracting COVID, and when they got COVID, they had more severe illness, and they also had harder time recovering from COVID. And that's because many people of color have pre-existing health conditions, and the big reason, the largest reason, is that we have had decades and decades, hundreds of years of disparate impact, persistent and systemic institutional racism that has impacted the health of people who are of color. And so what we also saw during the COVID pandemic is people of color were overrepresented in the frontline employment. When the state closed down, we identified essential workers and said that there were some people who had to keep working. And we know that many of those folks who had to continue to work were those people who were in the healthcare settings, people who were on the front line, people who were in nursing homes, and who had in the grocery stores, who had to have direct contact with the public. We also saw that many of those folks were those who had two jobs. And so they were dually or doubly exposed to the potential risk of COVID. And then some of them, many of them worked in employment settings where they did not have access to health insurance coverage and sick leave. And you all know that there's been a lot of focus on social determinants of health or social drivers of health. Those are those things that will impact our health but that are not directly related to medical care. And those things play a significant role. Access to food, access to transportation, those things play a huge role to people's health. And we find that access to health care and access to unmet social needs is a large driver in the system as well. And so some of the things that we saw in COVID are exactly the reasons why we are leading with equity at the department level. This is a statement that was written by the World Health Organization in 1946. And I heard someone talk earlier about these large health institutions where people of color had to get access to care through going through the basement. We believe that everybody needs to have access to care through the front door. And the World Health Organization said in 1946 that a rights-based approach to health care, that assumes that everybody has a right to health care. And if we believe that and want to take a rights-based approach to health care, then that means we have to prioritize the needs of people who are furthest behind in getting access to care. And I would say today that the people who are furthest behind are people who are historically marginalized. Those are people who historically and systemically have been denied access to care. That they've also been denied access to resources and to power and to political relationships as a result of the systemic, durable, and persistent racism and discrimination that we've seen in our society. Those are people who are often identified by their race, their socioeconomic status, where they live. We know that people who live in rural areas often are historically marginalized. And it's also people who identify based on their gender identity or their sexual orientation, and others who identify by their disability status. And I know I'm a person of faith, I'm a Christian by belief, and I know that I'm speaking to a lot of people of faith, and there are different beliefs that we have around gender expression and sexual orientation. I do want to say at the department level, we are advocating for health care for all people who are historically marginalized, and we want people to get well and to get access to care. And I talked a little bit about long-standing and well-documented cases of structural racism. The thing that I wanted to highlight here is diabetes is a major issue in our community, not only in our nation, but you can see that North Carolina experiences higher rates of diabetes. We know that African Americans, people who are American Indians, are experiencing higher rates of being diagnosed with diabetes, and you see the numbers that I've placed here on the screen. So So how do we move forward? And I know that I'm talking quick. I'm doing so because I want to be respectful of your agenda and not get things too much off time. But how do we move forward? One of the ways that we're going to do that is by addressing what I mentioned earlier with helping all North Carolinians have access to opportunity for good health. About 80% of your health outcome is determined by non-medical drivers of health. And those are the things that I talked about earlier. Your access, my access to food. I heard the minister speaking earlier about having a community garden. When I grew up in a small town in North Carolina where we grew our own vegetables. You know, we grew green beans and we grew cucumbers and tomatoes, and I didn't realize until many years later how privileged I was to have access to fresh fruits and vegetables. We don't grow many of our vegetables these days. Our food is being shipped in from various places across the country and even from other places outside the country. But there are many people who don't have access to healthy foods. There are many people who don't have access to transportation, and all those things obviously will impact people's access to health and have an opportunity for health. I would say poverty, as you know, is a huge driver, as well as having access to affordable and safe housing. Access to transportation, as I mentioned, and another area that we're focusing on is interpersonal violence, as we have almost half of the women in North Carolina who've experienced some type of take that call seriously. So what we're going to do is to focus on some core principles. We want to empower people. We want to make sure that equity is at the top of our list. We do need to make sure that there's health system capacity, and those were some of the things that we prioritized during the COVID pandemic. Obviously, we want to thank you for all of your efforts to making sure that people got vaccinated, because vaccines have proven to be the greatest weapon that we have in this fight against the COVID pandemic. As a part of our goal, how we recover strongly as a state, we are prioritizing three things. We want to focus on the behavioral health and resiliency of North Carolinians. We know that in addition to the physical impact that COVID has had on our state, it has had a tremendous impact on people's mental health conditions. It's had a tremendous impact on children and our ability to educate our children and make sure that they are doing well. And so that's another reason why we're focusing as our second priority on child and family well-being. And finally, one of our key priorities as a state is focusing on a strong and inclusive workforce. We need to find a way to make sure that our frontline workers and people who are caring for the people that we love can receive a livable wage and can be paid for the care that they're delivering. So what are some key things that I want you to take away from today? We have developed this framework for how we are going to take the lessons learned from COVID-19 and move forward. One of the things that we're going to focus on as a key component of our framework is earning and sustaining the trust of community partners, people like yourself who are trusted members of our community, faith leaders who, pardon me for that, I'm sorry. I hope that you can still see my PowerPoint. Faith leaders who are important members of our community to help convey information and also help individuals in our community be educated and move forward. So one of the things we're focusing on is building partnerships, as I'm mentioning, and earning trust. And that's critically important because we don't have a lot of trust in some places in our community. And that's partly because of the historic medical traumas that individuals experienced in our healthcare system. And so we recognize that we need to do something about it, and we're committed to doing so. And we want your partnership in doing that. One of the things that I take very seriously in my new role as Chief Health Equity Officer is evaluating how we can embed equity in the policies and operations of our state. We need to make sure that we're examining how we're treating people, the services and the care that we make available to folks, and we want to make care available to the people who are in greatest needs. And finally, we need to have shared accountability. Having clear and consistent data that tells us where the areas of greatest needs are. I heard, I think someone earlier today talking about, I think he said Southeast Greensboro as an area of greatest need. We need to look at the zip code level. We need to look at this at the neighborhood level to determine where there's areas of greatest needs and then target those areas for providing interventions and fiscal resources. Money needs to be poured into communities where it can make a difference. So what can you do? And what can I do? We take seriously our need to build partnerships with communities, and that's something that's going to be a priority of ours. We know that we need to improve language access. About 10% of the state of North Carolina are made up of people who speak Spanish as their first language, people who identify as Latinx or Latina. And so we need to make sure that materials we make available to them are in languages that they read and understand. We are going to continue to address those social drivers of health that I mentioned earlier: food, transportation, housing, and interpersonal violence. We want to and intend to use a data-driven approach to how we build services and program and address equity in our community. I believe we also have to engage providers of color. We have put some emphasis on the needs of people who are receiving services, but I also believe that providers of color are an essential player in our solution for addressing equity. And then finally, we need to measure what matters. We need to look at what kind of outcomes we're trying to achieve and focus on that, identifying where there are gaps and addressing those gaps in services first. So I believe that was my last slide, and with that, I'm going to stop sharing my screen. I hope that I didn't freeze up too much and you all were able to hear all that I had to offer. And thank you again for allowing me to join your presentation today. I would have preferred to have been there in person, but had a previous obligation that I couldn't pull away from. But thank you all, and I look forward to a future opportunity to talk with you.
Thank you so much. So we just cannot thank Deborah and the department enough just for their continued work around health equity and really building these partnerships. And to me, that's why I'm so excited why we're here today, because it takes all of us working together to make a difference and to really focus on what matters. Next, I'd like to go ahead and call we have Dr. Nadine Barrett, if she could come up. We're pleased to have her today. Nadine serves as the Assistant Professor, Family Medicine and Community Health for Duke University. And she's also in a new role as Director, Center for Equity and Research for the Duke Clinical Translational Science Institute. We're excited to have Dr. Barrett come today, as she can really help demystify and help us determine how to educate, empower, and equip to get more individuals of color into clinical trials. Thank you so much for your time today.
Thank you for having me. It is always a pleasure to be here. Reverend Dr. Mitchell, thank you always for your friendship, your partnership, your passion, and your commitment to our community and to ensuring that we get not just access to care, access to quality care, and that we are present and we are at the table. So thank you so much for your heart there. And I can't help but recognize also the rest of our HEAL partnership with AME Zion, Reverend Caldwell, Dr. Caldwell. I really appreciate you as well. And to all of you who are here, thank you for being here. And it's just really an honor to be able to just talk about things that have been on my heart and remain on our heart and the need of our community in incredible ways. I think it's really incredible because someone mentioned earlier how important it is for us to not get caught up in this idea of we have a deficit, that we are short of something as Black people. As a researcher, as a professor at Duke, is one of the biggest things that I think is critical is that we are not the problem. And I think it's important for us to know that. Does it mean that we can have opportunities to change? Who doesn't? What human being doesn't? But we are not the problem, right? And I think that that's really important for us to acknowledge and recognize, because oftentimes things are always framed, as Dr. Williams mentioned from Wayfarers, which I really appreciate what you shared, that it's so critical that we recognize that. We also then get to recognize what strengths do we have as Black people? What do we have as assets? And the faith ministry is one of the biggest areas in which every single time there's a need for us to make some change in our community, it always comes back to the church. The church plays a huge part in that. We talk about civil rights, right? Equality, seeking rights, where was the church? Front and center. We can go all the way back to slavery and see from back there, the church played a key part in that. And so if we're really going to have, as we have today, what we're calling a Faith Health Summit, then let's go ahead and talk about how faith can play a part in making a difference here. And let's also talk about how we are not going to take on labels that makes us into make us into the villain, make us into we are the problem, or make it into a way in which we cannot create the kind of change that we want to make and see in this world. So that being said, I have a few slides that I'm going to go through. Dr. Funderburg, if you could get me started on, oh, perfect, thank you. So absent. I started my slide by saying this because I think one of the critical things for us is that we're not present. We're not present at all. And we're not engaged in a way that allows us to show our expertise as Black people, our insights and our perspectives about our own communities, our family, our children, our lives. We are absent. We are not asked to come to the table until, basically, if you think about it like a restaurant, for example, you get invited to come out to eat, but already the restaurant's been selected, the menu's been selected, the food is already on the table, and we might get asked to see if we want dessert. That is not how it works, and that's not how partnerships works. That is not how equity works. And so today we're talking about what equity is and what it needs to be. And I will say, for me and for us and the relationships we have, is equity means that we recognize and acknowledge where things have gone awry. I was in a meeting, I just got here from DC last night, and we had a heated conversation. I'm serving on a board of trustees for one of these national organizations. And I'll tell you, one of the things I always find when I go to these meetings is oftentimes I'm probably the only Black person in these meetings. And therefore I end up having to stand up for who we are as Black people, because there's so many assumptions, stereotypes, and biases that even happens in all of these spaces. And in this meeting it was really interesting because they were asking me the question of, Nadine, how do we get past this? How do we move past this? How do we kind of move forward now? We know this is here, but how do we move forward? And I said, what do you mean by move forward and get past? Get past. You don't get past this. We have to go through it. Right. We have to go through it. We don't get past it. We have to go through it. And my second question was that oftentimes we get asked, well, what are the solutions? And we get asked the solutions at the wrong time, those kinds of questions. And so this question that was asked to me was, Nadine, well, what do you see as what the ideal situation of inclusion should look like so we can seek that? And I asked the person, well, help me out and understand, what work have you done to understand race and racism? Wow. What work have you personally done to understand how structural and systemic racism, slavery, and all the experiences of Black people both in the United States and across this globe, how that impacts our well-being and our life? What have you done to do that work? And let me ask you another question. When you're in a situation with people who look like you and people who look like me are not present at that table, which is probably more often than we'd like to admit half the time, what do you do to ensure that you're advocating as my ally as a Black person? I said, all of those things will take you to the answer of what the ideal role should be, but don't ask me that question. Not until you've done the work. Right. Not until you've done your own work. And so I will say to all of us here, and as we talk about it with United Health, which I always appreciate when we have great advocates that are coming out and wanting to really help us to work together and collaborate and partner, make sure we have done the work. Make sure that you have done the work. Make sure you understand what it means to be Black in this country. Understand what it means that me and my 100-year-old grandmother, who is here in the audience today with us, I know, we passed grandma's 100 just so I had to say that. My grandmother is 100 years old, who's here in this audience today. Ask us what the experiences that we have had, and I'm not a medical doctor, but I am a professor in family medicine and community health at Duke University, and yet when I go to an appointment, I get treated as if I am nobody. Wow. It's not until somebody hears or realizes that I actually work there or work at Duke and in the medical profession, and all of a sudden the whole interaction just completely changes magically. Right? So I think it's really important that when we think about our experiences and the inequities that exist, this is not just simply something that we're going through and we're experiencing and we're making up. George Floyd happened, but he was not the first. Right. But all of a sudden now this entire country made vision statements of how they're going to now focus on equity and structural systemic racism. Organizations made these huge pivots. And I'm not saying those things are wrong. I'm just saying that what did it take for Black people to be heard about what our experiences are when we actually show up at a doctor's appointment, when we're actually driving down the street, driving while Black are getting pulled aside. What does that mean? What does it take? It took cell phones in the middle of the street on Memorial Day with a man with a police officer on his neck when we actually all basically witnessed a public lynching in order for a Black voice, our voices of centuries, to be all of a sudden considered valid in 2020. Wow. That's what it took. So when people ask me questions like the meeting that I was in DC yesterday, I can't help but stop and keep saying over and over again, the answers to the questions in terms of what we know can make a difference belongs right here. The answer to what you can do to pass through it belongs with you. Belongs with the system. And you need to figure that part out before you consistently reach out to make a difference. Because you see, when you shake my hand and say you want to partner with me, for me it means you're partnering with me because you know me. You understand my experience and the experiences of my people. That's what partnership looks like. Partnership is just like, well, how do we move forward from here? Oh, no, you see, because I don't get that privilege as a Black woman. I don't get to just say, oh, we'll start here and move forward. I don't get to say we'll start here and move forward and making decisions about my health care and how I'm going to be treated or how my grandmother, my family will be treated when they show up in a clinic. I don't get that privilege to just move forward. No, I don't. Guess why? Because as soon as I've left you and told you about what the forward will mean, I walked into CVS, which just happened a few months ago. Walked into CVS, forgot my mask, so I turned around and ran back to my car to get my mask. And when I came back to the door, the staff was standing at the door asking me if I had taken things out of the store and put it in the back car of my sleeve. Wow. Okay, so let's really be real here and recognize that our experiences of Black people as Black people are constant. We don't get to take this skin off. We don't get to walk around every day and after we've said we're going to work on something and partner and make that change, we don't get to turn around the next day and not have to think about it until I see the next Black person. No, it is our lived experience everywhere we go. So as we move forward about what partnerships look like, that's what it means. It means understanding that experience and being willing to go through the pain, because our people have been going through the pain for centuries. Right. So let's go through it. Let's not pass by. Let's not say let's move forward and what does it look like in the future. Let's talk about what it looks like now. Right. Understand that, and then we can move forward. So I went way past because I forgot a whole bunch of slides that was off the record. But we could go to move to the next slide. But I think it's such a critical part of us really thinking about it. So when we talk about poor outcomes in our communities and what that actually means, I think it's important for us to understand, again, that equity and equality are two different things. Equity, let's start with equality. Equality, civil rights movement, that's what most people think about when they say, yes, I treat everyone the same. Do not treat us the same, because we're not. Right. So saying that you're going to give us all access to care is not enough. I lived in England, and in England, everyone has access to care. But guess what? The quality differs significantly from Black compared to white. Significantly. That's why disparities exist anyway. That's why Black people are still dying at higher rates in a country in which access is universal. Why? Because of stereotypes, assumptions, and this idea that as Black people, for some reason, we cannot show up and do well. We need help. We don't need your hand down. We need you to look up and recognize where we are. And that is where we as organizations have got to move to. When we look at all the disparities, cancer, cardiovascular disease, diabetes, HIV, mental health, in all of these areas, Black people fare worse than any other race and ethnic group. Does that mean we're short, we're deficit, we've got a problem? No. It means systemic and structural racism is alive and well. Right. It's alive and well. It has not changed. And so when we talk about equality, we're not looking for it. We're not looking for equality. That was a good move for the time, but we're looking for equity. Equity means that when we think about the race, and I always liken it to a race. Imagine us all starting in a race. We're getting ready to run, right? We got to stretch it out, get ready to do our big run. We're getting into a marathon, right? We're standing in that line, and then all of a sudden we're ready. And what happens? The gun goes off. Bam! White men start running. Keep running. Keep running. Keep running. Keep running. 400 years, bam! White women start running. Keep running. Keep running. Keep running. And if we really go out all the way to 500 plus years, then we can start saying, bam, black men start running. And as that race is going on, the first that starts the group, that starts the race, they determine what the health system will look like. They determine what the financial industry will look like. They determine what the policies are related to criminal justice and what the criminal justice system will look like. And when we talk about building relationships, everyone comes and we talk about this whole idea of trustworthiness. We want to build relationships, and yes, we do. We do. But understand that this is not the beginning of relationships. Relationships started over 400 plus years ago when it was based on the relationship between black and white in this country. That was the first relationship. And when we talk about building relationships, we automatically assume it's good. But that was a relationship. It was a relationship to say this is a relationship between black and white. Black people, you don't get anything. White people, every policy we make, we'll make sure that they don't. That was building a relationship. And today, when people come and want to talk about relationships, for me, it's important that we understand that history so that we can move forward, but we got to walk through it and go through it to get there, not past it. Next slide, please. So one of the things that I'll highlight, and I think it's really important, has been incredible for us, is our relationship with the HEAL partnership with Duke. And we can keep going a few slides ahead. I kind of just spoke from my heart more than the slides, so, but that's how that goes. This is important because, again, this slide here really highlights, again, every area in which there's plenty of research that shows implicit bias, stereotypes, racism, all contributes to poor health for black people, period. I have my colleagues who do incredible work around stress and looking at stress and racism, and it is clear that it has actually had a biological and physiological impact on us over generations as black people. So it's not that all of a sudden today we're stressed. We've been stressed for a very long time that has been passed over centuries, and I think that's important. Next slide, please. This highlights equality and equity, as I've mentioned before. We're looking for justice. Reverend Dr. Mitchell highlights this a lot. Our partnership, our HEAL work, we talk about justice. We're tired of equality because don't tell me we treat everyone the same because we're not the same. And that means you've not acknowledged me as a black woman in this country when you say you treat me like everyone else, right? That's number one. Number two, equity. Equity means that we recognize the marathon and the systems that have impacted our lives, including the health system. And until we're ready to truly interrogate that, change it, and truly dismantle it from the core of what it is, which means that these are systems that have been in place for over 400 years when we're talking about the healthcare system and any other system. It means we've got to be willing to do the work, right? And that includes the partnerships that we're building now with United Health and others. And then justice, this is what we want. And ultimately, there's actually a fourth picture now that my colleagues and I have made where we've actually taken down the fence and it's just we're there. Everyone is there being able to fully participate to their best abilities. Next slide, please. That's the marathon, I've done it already. We'll keep going. Again, the pillar, the Black church, that's a critical part. That's why we're having a Faith Health Summit. Next slide. These are some opportunities now that I'd like to highlight. And I feel like I wanted to say what I shared at the beginning because I think it's important that for the Black church and all of us here who are Black that have been living in, our parents, our grandparents, etc., have been teaching us about the church. We've been in the church. We know the scriptures, all of that. And I wanted to make sure that I was speaking to both audiences. All of us who are in the faith community and what we can do to make a difference, but also recognizing those who want to partner with us in different ways, understanding what that truly means in a really meaningful, authentic, loving, compassionate way. And I hope we understand that. I hope that that's what you hear from me. I'm very passionate when I get into my talking, but the power of that is when I'm talking about passion, compassion, understanding what it means to be Black, and then wanting to collaborate with us while you do your own work as well. Because we will never make the changes. Reverend Dr. Caldwell said earlier, asking United Health to go to the leadership and speak on our behalf because they're at the table. But in order to speak on our behalf, you've got to understand who we are and where we are and where we're coming from. We can't use the same language saying that we're short or we're deficit as a people when we're not, right? So really having that piece there. Our Health Partnership has been outstanding. We've been now, 6 years in the making. With this partnership between Duke and AME Zion, North Carolina churches, 17 churches here, we have been able to do some incredible work to address some of the specific disparities. And now I'm talking to people who look like me and the rest of our community and everyone else too. When we look at, for example, advanced care planning, we know that patients, the people who look like us, do not get the same kind of communication with our providers as our white counterparts do. And so one of the partnerships that we have is what we call Equal Space. It's addressing advanced care planning because we do know that when people have advanced care planning set up in their life with their families, and hear me clearly, it is not just for old people. It's not for people who are getting sick. Advanced care planning can happen from someone from the age of 30 on. Understanding what the wishes are, what the desires are, etc. It can happen for anyone. Advanced care planning, through this work, we are actually helping to help address that lack of communication when we cannot make decisions for ourselves, or when our family members, as was mentioned earlier about caregivers, allowing our caregivers to know what is important to us so that they can also advocate on our behalf. My mother passed away 3 months ago, and I tell you, the biggest gift she gave me was having this advanced care planning in place, because she was ready every way possible, spiritually, but physically she wanted to make sure these needs were taken care of as well. So advanced care planning is one of our projects, if we go to the next slide, that we've been working on. Equal Space. This is AME Zion, 17 churches working to have health ministry leaders working toward ensuring that our congregations and our community is aware and able to have access. Right now, when we look at advanced care planning, 19% of Black people in this country have advanced care planning in place compared to 75% of white people. There's a need, and white people get significantly more communication, information when they see their providers compared to white people. So we have to start thinking about how do we start to close those gaps, and that is what this partnership is about. Next slide. A training that we developed to address our implicit bias called Just Ask. The AME Zion partnership played a huge part in us really bringing this together, where we now start training our physicians and our researchers on how to interact with us in a way that respects us, values our culture, and asks the questions in these 3-minute meetings that we have with our providers. And so this training has now been, you can go to the next slide, has now been passed over with all these national organizations, and is now about to get rolled out nationally for researchers and physicians to understand their stereotypes, their racism, and their implicit biases, and how that impacts the interaction between them and their patients, particularly Black and other race and ethnic groups. Next slide, please. That's the same. That's just, again, the announcement that came out with the press release. This is another partnership that we've worked on too in addressing, and one of the things we're doing in multiple ways is making sure that when we do research in that community together, that we also provide something. So it's not just that we're coming in to do research, but what is it that can be meaningful for us at the time, for us as individuals to act upon. And so this is a project that was actually done with another church, but it's also a partner with AME Zion, with the River Church in Durham, and this led to what we're now doing also with AME Zion in different ways as well, where we actually, there's a bacteria in our stomach called H. pylori, and when it gets infected, it's actually the bacteria that causes stomach cancer. Black people are more likely to die from stomach cancer compared to their white counterparts. So we created a clinical research study in their midweek service. 92 people came out, actually participated in this clinical study that both allowed them to see if they had H. pylori infection, and we were also able to address the disparities between Blacks and whites through that same study. What's really incredible about it is that the people that went through it actually did have, 25% had H. pylori infection. All it takes is 2 rounds of antibiotic to get rid of it, and you will never have stomach cancer. So they all got 2 rounds of antibiotics, so now they were also cured, and we had a preventive space of them from getting stomach cancer, and at the same time they also participated in a clinical study. So it was mutually beneficial because now we could address it for the rest of the country because of what we did in one church. Next slide. Care and Justice, you can click again, I think the next piece, there we go. This is a study that's called Care and Justice. Now, AME Zion is our primary partners in this study. And this again is another important reason for why we as Black people have got to be in these studies. We've got to be, and we should know, of course, make informed decisions, but it is so critical for us to be in it, because in order for us to close those gaps, it will take us to be a part of that in order to make that change. H. pylori, we can address this now for the Black community across the country by just having 92 people locally participating through a church. This is another study, you can go to the next slide. This is around kidney disease. This is AME Zion, our #1 partner in this. And again, this partner is equitable. When people reach out to us to start doing work, it's always important that we sit down and we talk about not just the work, but also what's my expectations? How do we manage that partnership? And how do we manage the finances behind it? So here, Black Americans are 4 times more likely to die from kidney failure than white Americans, and look at the stark difference between the two. The next slide. They're also more likely to, this is the same slide, actually just highlights it in a different way, the number of Black people compared to whites, and yet we are much smaller in the percentage of the population compared to white counterparts. Next slide. 8 in 10 people with kidney disease do not even know they have the disease, and that's specifically and even more so for people who are Black, of African ancestry. Next slide. I kind of highlighted the 8 this time. Next slide. I was taking on the point. And then can you just take one more time on that? This slide here. Yeah, all the way until you keep clicking until you'll see this bottom piece come down. This is what's important. Kidney disease. Kidney disease, Black people are dying at the same rates of Black women with breast cancer and Black men with colon cancer. And yet we don't talk about kidney disease half at the rate that we need to be talking about. So this partnership, next slide, is specifically addressing that. You can go on to the next slide. There's history around African ancestry, but I won't go into that because I know my time is just about done. Approximately 4 in 10 Black Americans are on dialysis, and interestingly, over a 3-year period, if someone's on dialysis, 50% of Black people who are on dialysis within those 3 years will die, and compared to their white counterparts. Again, huge needs for this. Next slide. And so this allows us to, again, recognize the importance of us being involved in clinical trials around kidney disease so that we can help save the lives of ourselves, our families, and members, etc. Last slide here. We are recruiting 5,000 people who are all of African ancestry to be a part of this. The HEAL partnership is critical to this. And basically what we need people do is they give their urine. We check to see if there's protein in the urine. If there's protein in the urine, we actually are able to then move forward and help them to know how to address their kidney health. Then if they move forward and decide they want to be a part of the clinical study, we include them in the clinical study. We get 2 teaspoons of blood, and with that, we're actually able to do genotyping to not just know their own situation in terms of the relates to kidney disease, but that of their family members as well, because as we know, there's a gene that actually is connected to that goes across generations around kidney disease. This study, Opie Olabisi, I showed him in the earlier picture, he is the PI of this. And again, with us, we're recruiting 5,000 people to be a part of this. We're asking people to be partners, our community to partner with us as other Black people doing research so that we can start making a difference in our own community. Last slide, and then we can keep moving from there. That's just some of the eligibility criteria. And then the 3 goals, as I mentioned, is here. Our ultimate is that we'll take that blood and actually be able to do a clinical trial in a disc, because we believe that, how many of you heard of rheumatoid arthritis? Okay, so there's a drug for RA that we believe actually will shut that gene down that actually impacts kidney disease, so we could ultimately end up eradicating a significant part of kidney disease with this. So it is really an opportunity, again, for us as Black people, Black researchers, to work with our Black community toward creating the kind of change that we need. Last slide. The call to action then is very easy and very simple. When we have a partnership like what we have at AME Zion, we could not, I'm telling you, because it's not just here, it's all this research that's happening across Duke. AME Zion faith leaders have given insight, input, direction, guidance, has told us when we're going the wrong path, the wrong track, how to fix things, change it, modify. They are critical partners. Their insights are beyond anything. Science and research, and therefore health outcomes is better because of this partnership. And I think it's important that we recognize that as a community, but we also recognize it as individuals. When people ask you to participate in a study, reach out to people, reach out to our faith leaders and others to figure out what is best for you and how can it contribute to addressing health disparities in our community. And when we talk about aligning partnerships with organizations, ensuring that it's equitable, ensuring that we are doing the work to understand what is the experience of being Black and how that plays out in terms of our relationship and our partnership. What does it mean to be an ally to the Black community is a critical part of partnership. I don't want to be a partner with you if you're not an ally for me and my work and my experiences. And so I think that that's a critical part as well. And last but not least, making sure that we do our best. So when we go to see our appointments, we go to our doctor's appointments. I know I always say I'm going to my doctor's appointment. When I walk in there, the provider asks me, how am I doing? To your point earlier, Dr. Funderburg, is that I will go in and I'll have all this thing, a list of all kinds of things going on. The minute I sit down, the doctor turns around and says, okay, Nadine, how's everything going? I'm like, I'm doing really well. Thank you. Like, what happened? What happened? I had a list down there, exactly everything. So really and truly, I think identifying people who can hold each other accountable. So when we go in that meeting, we don't say we're fine, but we have the list there. And we also make sure that that provider listens to what our concerns are, listens to our situations. And if you can bring a friend with you, bring a friend, bring your caregiver, because they can also take notes and advocate for you too. And on that note, we're looking at all different levels, community, partnerships, the role of faith organizations in really becoming the key part of addressing these health disparities and advancing equity, and for our partners and organizations that come to partner with us as a Black community, ensuring you understand our plight, understand our challenges, and recognize that we are strong Black people. We come from a group of ancestors that we stand on their shoulders, and without my ancestors, I would never be where I am today. And let me never forget that. And we ask for our partners to never forget who we are. We are still here after slavery. We are still here after apartheid in Africa. We are still here. Recognize who we are and what we bring. Thank you all.
My hair is blown back. That is incredible. And I don't feel worthy to follow that. Dr. Barrett, thank you. I almost wish that we had an entire afternoon to really dig into all of this. It's so important. I think what really stood out at me is that we can't get past it. We have to go through it. And that we need to do the work now and take action. And so thank you so much. I want to just pivot for a moment. We have Sharon Pouncey with us today. She manages our community collaboration team. And I think as we really look at, getting past partnerships, we desire to build authentic relationships with our faith-based organizations throughout the state, as well as our other community partners. And Sharon just really wants to bring home some of the value that we can bring as that trusted advisor. So with that, I'm going to turn it over to Sharon.
Thanks, everyone. As part of the planning committee, I don't know what made me decide to follow the last speaker. That was just amazing. United Healthcare gave me the opportunity in 2019 to come in and talk about our new managed Medicaid and how it's going to impact the communities that are affected here, that we're discussing here today. And I thought it was just an awesome opportunity. Talk about being blessed and highly favored. I was in the right place at the right time, and I hope that what I'm doing is good. So I'm just going to talk a little bit about what United Healthcare has given me the power to do in our community when it comes to these relationships. You can go on to the next slide. So this is our mission. This is what I go out and I start talking about when I'm discussing United Healthcare and I'm talking about managed Medicare. We try to help people live healthier lives, help the health system work better for everyone. And then everything I heard today floods through my mind. It's not for everyone. It's not for me. I have this exact same story that Pastor Odell has, except it wasn't my mother, it was me. And it was something as simple as a gallbladder. And I went to the doctor over and over and over again. And all he would do was give me pain medicine as if I was just in pain. And it wasn't until I went to work, fainted, was rushed to the hospital, violently ill, and even the ambulance workers were saying, oh, it's just gas. It's just gas. He didn't even think they should finish the trip. When I got into the ER, they came back in about 2 hours and said not only was my gallbladder inflamed, it was infected. And so not just the normal surgery, but I had to be hospitalized and put on all kinds of medication when all I needed was something simple, and no one would listen to me. So when I say these things, when I'm out in the field, I realize the power I have. And I thank God that I have the power of a company like United Healthcare who's giving me the power to talk to you and the power to make these relationships. So I'm going to skip ahead and talk about our value benefits. Go ahead. Thank you so much, Keith, I think you went ahead one. Go ahead, one more. Okay, we'll stop here. So some of the things that we were talking about that goes on in the communities, our affected communities, is the need for fresh food, food deserts, all of the problems that we have when it comes to obtaining the right foods, because foods are medicine. So United Healthcare, when we partner, when we make these plans, when we think about this community that we want to partner with, that's why we're standing here, we think about what can we bring to the table. So one of the things that we bring to the table is $175 a month for our seniors with fresh food. One of the things that we bring is dental benefits, because we know that oral hygiene is something that affects hearts. Heart disease can develop from that. So benefits that are not given to our seniors, United Healthcare provides. Zero copay for medications, zero copay for eye care, routine eye visit, free glasses once every 3 years. So things, basic needs that we have that affect our overall health, because I don't care what you say, without my glasses, I can't see what's going on in my life. How can I live effectively? Okay? We need those things. For our Medicaid plan, there we go. The state came out with a Medicaid plan, and everyone who received normal Medicaid now belongs to a managed Medicaid plan. And I was charged with going out into the community and telling everyone about this wonderful plan. But the plan wasn't just about health. United Healthcare recognized that 80-20%, that 80-20 split. 80% of what's going on in the lives of the people who are Medicaid eligible that's affecting their health has nothing to do with what's going on in the doctor's office. So our benefits that we actually put some thought into to help our members and hit those social determinants of health are as follows. Breast pumps. Healthy First Steps program is a program for mothers, pregnant mothers, that follow them from the first trimester all the way to that baby's first birthday. And in between are specific steps that they have to take in a doctor's office to ensure not only the child's health, but their health. They get rewarded along the way because we need them in those offices having it if we're going to do anything about the child death mortal rate in this state. One of the other things we do, we have a Weight Watchers program. We talk about food, we talk about diet, we talk about health. 13 weeks, GED vouchers, education is a must. Wellness visits, even for adults. If you're on Medicaid, or even our seniors who are on Medicaid, you get assistance and help along the way to help you make those wellness visits. All of the doctors that stood before you today explained to everyone those wellness visits prevent all the diseases that are destroying our community where the disparities lie. Transportation to employment-related needs. Now everyone says, oh, I need a visit to the doctor, I need a ride to go get my medicine. Who even thinks that, okay, the medicine today is that I need this job, but how am I going to get there? That's what these benefits that United Healthcare and the state came up with, so that we can stop that hand down and give it a look up. That's what I heard. That's what this is about. Assistance for asthmatics, keep them out of emergency rooms. The biggest problem for people with asthma who are in these affected areas is they end up in emergency rooms with huge bills. And something as simple as a hypoallergenic pillowcase can stop an attack. So those are the kind of things that we're bringing. Fresh UDT benefits, where you're going to get fresh food when you can get to a store that can give you fresh food. See, those are issues I can't address. That's what I'm here discussing. That's what we're partnershiping on. Next slide, please. Okay, so how are we going to collaborate and make this change and make healthier communities? These are some of the things that the church can do, and I might have a few more than is on this particular slide, so bear with me. So what the church is going to start to do is educate your neighbors and the people who belong to your church in this community about the managed Medicare plan. There's so many people around you who are on this Medicaid plan and don't even understand what their benefits are and how these benefits are designed to help them overall, not just to go to the doctor. Distribute the notices from the states when the state put out advisories about COVID, when the state puts out advisories about the new strains, anything that you can do that informs our community. Update the community about open enrollment. Some of our people lose their benefits just because they don't know that they have to re-enroll. There's so many things that we can do. Send reminders of key dates. Encourage neighbors to exercise and choose their right to choose a plan that's going to work for them. The next thing we can do is encourage our members in impacted areas to utilize their preventive care visits. I can't say that enough. We have to start being preventive and stopping these issues from overtaking our community. And if something as simple as a yearly visit that you can receive a $50 benefit for, why not? Next slide, please. These are some of the ways that United Healthcare has already communicated and part in this community. And I heard today action. When we were planning this, I said, we got a lot of people talking, but what are we doing? I need to know what we're going to do. I'm a community collaborative advocate, and that means I go out and find something to help United Healthcare help in the community. So these are some of the ways. We have our fresh food giveaways with our partnership with Second Harvest Food Bank. That's all across the state of North Carolina. And that means I could partner with a church to set up a new food bank once a week, once a month, every week. We had the first in Greensboro, before the health department, before they started at the Coliseum, with our partnership with Triad Pediatric Adult Medicine. We did the first testing in Greensboro Housing Authority with our seniors. We were actually doing the vaccines in the community with our partnership with United Healthcare and Triad Pediatric Adult Medicine before they started having me drive through the parking lot in the Coliseum. So federally qualified health centers accept our Medicaid plan, but they also accept people who don't have a job, who don't have an income. They work on a sliding scale. Those are the partners that we want to come out and help with us in the church, and we can do that. We can make that happen. So community baby showers, because this is something that we promised as a value add. We go out in the community, but we don't just give away things. My last baby shower, we had doulas. We had the Department of Health Pregnancy Maternity Program. We had the United Healthcare Maternity Program. We had 2 pediatric doctors discussing postpartum depression, the difference between postpartum depression and baby blues, and some of the care that the mother is going to need afterwards. This isn't about just going out and giving away things. This is about bringing the information that we need to make the difference in our community, and United Healthcare recognizes that, and I am thankful that they have given me the power to do anything I need to do to address that issue. Next slide, please. Some other ways we can be helpful. United Healthcare and your nurse ministry collaborating and facilitating on things like blood pressure clinics right here in the church. You don't have to come to us. We can bring it to you. Diabetes workshops, healthy eating workshops. So you get a healthy care package from Second Harvest Food Bank, but I don't know how to cook any of that stuff. So now I bring a chef here, and I say, let's cook this up. Let's show you how to eat healthy. That's how our partnerships work. Next slide, please. Now in this state, there are right now currently 5 agents that do the same thing that I do here in Greensboro, and a lot of people here know me. I'm Sharon Pouncey. We have Delana Epps. She's out of Raleigh, and she takes care of that Raleigh-Durham area. We have Jamie. Jamie's in the back. She handles Region 6, which is a little bit past Raleigh. We have Jamie, we have, Paige. Sorry, Paige, I forgot you. Paige is in the Fayetteville area, and then we have Bonnie, Riley Bonner. She is also out in the Asheville area. And we all do the same things in these 6 regions to help connect the community and the church, as well as our community partners with the church to help with these disparities. Next slide. That was an event that we did at Mount Zion Baptist Church during COVID, where Marcus Thomas fed over, I believe we did 800 boxes that day during COVID, with the partnerships and help of different community relationships like Out of the Garden and United Healthcare. It isn't about what United Healthcare can just bring to the table, it's how we can connect. And the first thing that I would like for you guys to understand is that all of the disparities, all of the problems, all of the things that we hear about the medical community over the years has taken away the power. People go to the doctor and they say, I'm fine, when they're not. Our Medicaid members, our members who belong to the Medicaid role for years went to doctor's appointment that folded pieces of paper. And I've heard so many of them say, I didn't even want to go because I didn't want to pull out that piece of paper. They had no power. They felt they didn't deserve the best care. They felt they deserved exactly what that folded piece of paper said. United Healthcare gives them a Medicaid card, but their card looks just like yours and mine. So when they go to the doctor, they have power. They have the power of an insurance company behind them that says, you have to treat me well. But they don't know that. So I'm asking the church, as your first action, every one of you leaders, let the people know they have power. You have the right to walk into any doctor's office and to say, you're going to give me the care I deserve. Doesn't matter what I have in my pocket. I'm here to be treated and treated well. And if you don't find it with that doctor, your voice is, I get to go somewhere else until I get the care and the treatment that I deserve. So let's make that our first point of action. Give people back the power that they need to get the care that they need. And then this group right here, we'll work on other stuff in the background. Thank you.
All right, how's everybody doing? Good, good. Look, we're almost done, y'all. Thank y'all for being with us today. My name is Keith Funderburg. I'm one of the development directors with United Healthcare. I tell you, I'm working with an organization that cares about people. That's something that I learned also from my mentor, Bishop Brooks, and this is just an opportunity to do that all across the state. When my friend and manager, Karina Miller, she and I were talking about this conference, and we spent many hours just talking about it, and believe it or not, y'all, we were praying about it too. And we can see the success of it today. But what we want to do, we want to go past that. We want to go to that next step, the next level. So one of the things that we want to do is that we need to do this again with more people. We want to do this across the state. We need to have a follow-up to these discussions, what we will do and how we will do it. And that's going to be, we're going to do a think tank. We want to do something. We want to establish a Faith Health Equity Council that we can educate the different individuals all across the state, and specifically with pastors. You know, I do this, I work at United Healthcare, but before I became here, I was a licensed minister. And Bishop Brooks was my mentor, and he trained me throughout those years. And so this is going to be an opportunity, and this is not just for black folk. Look, this is for folks that want to have a healthy life. Okay? And so that's what we want to do. We're going to email you a survey. In that survey, of course, we're going to evaluate today's summit. But secondly, if you want to participate in this Faith Health Equity Council, please just let us know. We're going to try to meet. We don't want to take up too much of your time, but we really want to take this to another level. and see what we can do for our community. So thank y'all for coming on behalf of United Healthcare. Again, my manager, of Karina, and of course the president, Anita Bachman. Thank y'all for being with us today. I'm going to send it over to Pastor, the man of the house, and I think he's going to close out with his closing comments.
Can we thank God again for this wonderful experience today? And thank you. Can you celebrate yourselves for coming into this space? I am so honored that we had this opportunity to be together, and this has been a very robust gathering. All that we are is because of relationships, and Trinity knows this for sure. Relationships matter, and we try to collaborate. I like the terms that I've heard all day. I'm not going to rehash or rehearse. It's been a wonderful day. You've been a wonderful people. Those who are watching us online, thank you for joining us. Those who have communicated and connected with us. Let me just take a moment of personal privilege to thank my dear friend and classmate, Reverend Odell Cleveland, for making the connection with me to connect with Karina that made this summer possible. Thank you, man. He is right, my GPA is lower than his, but I still teach at his seminary. So I'm grateful and thankful for that. And indeed, he has done tremendous work since our graduation 25 years ago. Wow. Amen. It's been 25 years this year, so good to see him. And it's good to be in this. He talked about Greensboro when we were in seminary. Mount Zion, Mount Zion, Mount Zion. And then finally, I have the privilege of pastoring here in the Greensboro community. So I'm thankful and grateful to be here. To all of you, thank you, pastors, preachers, I see you where you are. Thank you, those who have joined us. Thank you for coming. Let me thank the greatest church on planet Earth, the Trinity AME Zion Church, our staff, our leaders, our volunteers who invested their time and energy and effort to make sure that this was a tremendous success. And I believe that once we go forward from here, we need to activate, we need to agitate, we need to advocate, and then we need to allocate. Say amen. Amen. Time, energy, and effort, and dollars, because we don't need to build any more churches. Amen. We don't need to build any more family life centers. We don't need any of that. What we need is medical facilities that will minister to the least, the last, the lost, and the unloved. So let's work together. Let's partner. Let's keep this partnership moving. I celebrate what has been said. I celebrate and even support, particularly the action items that Sharon lifted up and Minister Keith lifted up. I want to make sure that we stay connected. Let's do that to the best of our ability. Amen? Amen. Now, there was a story told of an empty church building that a Presbyterian minister was selling. And he said to anybody who would spend the night in that church, he'd give it to them for free. And so the Baptists went in, and the ghosts would come out at night. And the Baptists went in, and the Baptists looked at all those ghosts. He said, no, I can't stay. He ran. Pentecostal preacher came in, saw these ghosts, and it wasn't the Holy Ghost, so he left. Methodist showed up, saw all these ghosts moving around him, looked around and saw all these ghosts and said, you know what, since all of y'all are here, we might as well have an offering. The Methodists are known for taking an offering. So as the ushers come, I'm kidding. Here's what I'm asking you to do. Don't give an offering here. Give an offering out there. Offer yourself to people who need you, and let's be a blessing while we have breath in our bodies. Thank God, as always, to have the senior statesman in our midst, Bishop George W. Brooks. Amen. Now we have box lunches downstairs. If your palate is not commensurate or consistent with what we have in the box lunch, go to any restaurant in town and ask for the George W. Brooks discount. And if they give it to you, call me back so I can go. I'm going to ask the bishop if he will come and give us a closing prayer. the box lunches are downstairs. Please feel free to take one as you go. God bless you. Thank you so much for being here with us. I love you. There's nothing you can do about it. Love you, Karina. Thank you for all that you do. Thank you, Keith. Thank God for all of you. Amen.
The reason the Methodists took the offering, the Baptists knew where to spend it. Shall we stand? God, we're grateful and thankful for the privilege to know you and to know those who care about your creation. God, we thank you for all that has been presented today. And we pray that our lives would be full of joy, peace, tranquility, and the ability to help others. Order our steps in your word. Let no iniquity have dominion over us so long as we shall live. Now may the grace of our Lord and Savior Jesus Christ rest, rule, and abide with you henceforth and forevermore is our prayer and benediction. In Jesus' name we pray. Amen. Amen.